Before we get started, I'd like to announce a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few business days after the call. You will receive an email from AHIP that will ask if you would like to receive the archive. Please respond to the email if you would. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the handout section at the bottom of your screen. The antitrust statement prohibits us from discussing competitively sensitive information. Please keep in mind you may ask a question at any time during the presentation by typing your question into the question and answer box on the right of your screen. Once complete, please press enter. Please refresh your screen at any time if you are having trouble seeing the slides presented in today's webinar. We're very fortunate to have with us Steve Wogen, Chief Growth Officer, CareCentrix, and Dr. Michael Cantor, Chief Medical Officer, CareCentrix. Steve Wogen brings more than 25 years of experience in healthcare as Chief Growth Officer at CareCentrix, where he is responsible for growth strategy, medical economics, sales, and marketing. Steve previously served in executive leadership positions at well-known organizations, Medco and Cigna, and he has also published and presented his work on electronic prescribing, the value of pharmaceuticals in care management, Medicare Part D, and efficiency in healthcare delivery. Dr. Michael Cantor is a geriatrician and attorney with extensive experience in designing and implementing population health and quality improvement programs for health plans and healthcare providers. He's previously held leadership positions for the New England Quality Care Alliance, served as founding medical director for the NEQCA Medicare Shared Savings ACO, and was the first CMO for Minuteman Health. He trained in internal medicine at Beth Israel Hospital in Boston and did his geriatrics fellowship at Harvard Medical School. At this time, I'd like to turn the floor over to our speakers.
All right, thank you. This is Steve Wogen with CareCentrix, and thanks for joining today. We have a lot of ground to cover, so we'll move relatively quickly, and hopefully we'll have some time for questions at the end. I wanted just to set the stage by recognizing the fact that we at CareCentrix believe that one of the best ways to effectively manage care costs for Medicare Advantage plans is by better management of post-acute care. And when we talk about post-acute care, we're referring to it holistically, including everything that's happening with a facility as a patient leaves the hospital, as well as all readmission expenses, which we think is an important component that we'll talk about more over the course of the afternoon. But post-acute care, it's large, it's growing, it's extremely fragmented, and the way it's delivered, the way managed care, post-acute care is delivered across Medicare Advantage plans is highly variable and highly siloed today. And it really puts the patient and the caregiver of the patient in a terrible position that can drive poor outcomes as well as higher overall costs. And by successfully coordinating care from a clinical perspective, aligning and thinking about your post-acute care network differently, and engaging the patient and the caregivers with successful readmissions management programs, there's a significant opportunity to reduce costs. And we've seen cost opportunity reductions anywhere from $10 up to $20 or $30 per member per month, which, if incorporated into a Medicare bid, is a significant advantage for any plan that's successfully managing this post-acute care space. And not only are you lowering costs, you're better engaging a patient, which overall is going to improve retention and simplify your open enrollment process, which will also lower G&A costs. So over the course of the next 40 minutes or so, we're going to cover a couple things on the agenda. The first is a high-level overview of the opportunity. I'll cover that. Then I'll turn it over to Dr. Cantor, who will talk about ways to optimize the pathway of care for a patient from a clinical perspective. And then I'll bring us home by talking about how to optimize the patient experience and how this can lead to lower costs and, again, improve member retention, and then some action steps at the end of the day before we get through Q&A. So with that, let's move to the slide on the opportunity. We do believe, as I mentioned, that driving care to the home is really the best way to bend the cost curve in healthcare today. Post-acute care, when you use the holistic definition I talked about at the beginning of the session, including SNF and institutional rehab and your LTAC and your durable medical equipment and your home nursing and your readmissions, represents one of every $4 that most Medicare Advantage plans would spend. And that spending continues to go up. Over the last decade, it's more than doubled. It continues to go up at 6 to 8% a year. And post-acute care continues to be highly variable. The Institute of Medicine published a study a number of years ago, 2013, so it seems a little dated, but I think the findings still stand up in the data, and we'll show some of that to you today, that demonstrated that 73% of all of the variability across regions in healthcare costs is driven by post-acute care. 0% in ER, as an example. So post-acute care is the largest driver of variability, and the system's really been built to optimize the profit potential of each silo in the continuum, as opposed to managing the patient holistically. And by managing the patient holistically, costs can be lowered by 20 to 25%, and again incorporated into your bids. We do believe that PAC management is critical for Medicare Advantage plans, and when you think about the spend and the number of patients that are impacted by post-acute care today, about 1 in 5 patients, I think most of you would find, are admitted to the hospital at some point, and of those, about 40% are discharged to a post-acute facility, whether it's a skilled nursing facility, a home health agency, or an institutional rehab. And those numbers vary pretty significantly, again, by region. In some markets, institutional rehab spend may be near zero. In other cases, it could be 10% or more of total facility-based post-acute care spend. But the one thing I do want to call out on here, and we'll come back to it, are these patients that go home alone. So about half of patients that are admitted to the hospital are discharged without any type of care at all in a home-based setting. And those patients that go home alone will drive a significant amount of costs, not traditional post-acute care costs, but readmissions costs. Again, we'll touch more on that in a minute. But when you think about what's happening when a patient's discharged, not all patients are created equally. So the diagnosis of a particular patient is a good indicator of what percent of their total costs 90 days post their discharge are going to be absorbed within the post-acute care setting. You can look at certain conditions like spinal fusion over on the right-hand side, where less than a third of the costs are related to post-acute care. It's really successfully managing that patient is about managing the inpatient stay and the rehabilitation that patient may need, but again on the inpatient side. When you look at more chronic diseases, whether it's CHF or COPD or renal failure, more than 70% of the costs for managing those patients for 90 days post-discharge, or for 90 days from the point of admission, are really associated with post-acute care costs. So successfully managing the patients with ongoing chronic disease is critical to manage the post-acute care costs effectively. I mentioned before that you need to manage the patients that are going home alone. And when you look at total post-acute care costs, which are outlined on the slide here, traditionally we think about the facility-based cost. Right? Facility-based spend is about 40% of the total post-acute care cost. A good bit of that is in skilled nursing facility, a little bit of institutional rehabilitation and long-term acute care hospitalizations. But again, the majority of it in skilled nursing facility care. And very often when you think about a post-acute care management program, the focus ends up being on the SNF. How do I cut SNFs out of my network? How do I build value-based SNF arrangements? How do I lower the length of stay for skilled nursing facilities? And all that's important to do in a clinically appropriate way that makes sense for the patient. But when you think about post-acute care holistically, about 50% of all of the post-acute care costs, again, we're looking at this on a 90-day post-discharge basis, are for readmissions. And of those, half of the readmission costs are for patients who go home alone. go home without any type of service at all. And by providing them with just basics, a single visit, a single external touch point, you can reduce those readmission costs pretty significantly. I would encourage everyone on the phone to work with your actuaries to better understand the distribution of your post-acute care costs in this way. Look at where those readmissions are coming from, because from an intervention perspective, a clinical programmatic perspective, the intervention that you would have in place for each of these slices of the pie varies pretty significantly. And better understanding what this distribution looks like for your population is absolutely critical to effectively managing post-acute care. So with that as background, again, post-acute being high cost and growing, need to focus on a patient holistically, not only managing skilled nursing facilities, but also managing readmissions and focusing on the population that's going home alone in order to manage total costs. I'm going to turn it over to Dr. Cantor, who's going to walk through some of the levers you may be able to pull to effectively manage this population, lower costs, and then incorporate that into your Medicare bid.
Dr. Thanks, Cantor. Steve. Good afternoon, everyone. Thanks for joining us. Mike Cantor here, Chief Medical Officer for CareCentrix. Happy to talk with you for the next few minutes about how to understand where patients need to go after they leave the hospital and how to make sure that they go to the right place that meets their needs for healing and rehabilitation and supports them as they transition from hospital to home, or from hospital to facility and facility to home. Our goal is always home first if possible, and over the next few slides we'll understand why that's becoming so important. One of the interesting things about post-acute care that you'll see on the next slide is that there are inconsistent discharge patterns, that patients, when leaving hospitals, often go to different locations. There we go. So on this slide, what it's showing you is that different hospitals discharge to different locations. So as you look across the slide, in the left column, you see where the patient goes after leaving the hospital: inpatient rehab facility or IRF, skilled nursing facility or SNF, home with care, home health services, including home nursing, durable medical equipment, home infusion, or home alone, home without any support services. And what you see in the next three columns are the patterns for Hospital A, Hospital B, and Hospital C. Let's just take a look at the skilled nursing facility or SNF discharge patterns. So Hospital A discharges 22% of their patients to a skilled nursing facility. Hospital B discharges 40% of their patients to a skilled nursing facility. And Hospital C, 23% go to skilled nursing facility. Now, it's possible that the population at Hospital B needs twice as much skilled nursing facility care as compared to Hospitals A and C, but very unlikely. This variability probably is related to sort of habits that hospital discharge planning staff has, or the way that the physicians who are managing those patients, or the discharge planners managing those patients, think about the need for patients to go to skilled nursing facility. It's this kind of variability, which is unrelated to patient needs, that presents the greatest opportunity to both improve the quality of care by reducing the risks of skilled nursing facility admission, for example, and to lower costs by avoiding expensive SNF stays, and potentially even reducing readmissions by making sure patients get what they need specific to their needs, rather than sort of generically sending everyone with a certain diagnosis to a certain location after discharge for care. Next slide. On this slide, what we see is that the cost per treatment for patients coming out of the hospital varies a lot by setting. So obviously, home health, where people are visiting periodically to provide home nursing or home physical therapy or whatever is needed, is less expensive than a skilled nursing facility, where patients are getting room and board plus daily visits or even hourly visits if needed from their staff, which is also less expensive in turn than inpatient rehab facilities or long-term acute care hospitals. What's interesting about this slide is it shows for specific conditions like stroke, hip and femur procedures for trauma, those are hip fractures, or for cardiac bypass. Basically what this shows is that there are some patients who can go to lower intensity settings like skilled nursing facilities compared to inpatient rehab and still do just as well in terms of their results, but at much lower cost. And I'll explain some of this a little bit later on. But you see here from the quote on the bottom of the slide that a recent study that looked at knee replacements found out that patients who went home, and they did a randomized controlled trial of sending patients home after their surgery versus to skilled nursing facility, the patients at home did just as well 26 weeks after the surgery as those that were admitted to skilled nursing facilities. So the data are there that for certain kinds of patients, making sure, of course, that they have the right support at home, that they don't have comorbidities that require them to be in an inpatient setting, that it is possible to send people home directly from the hospital even after a procedure as complicated as a knee replacement surgery. Next slide, please. Another way of looking at this is asking the question of whether it's appropriate for a patient to be discharged to home or skilled nursing facility, inpatient rehab, or long-term care hospital. And each of these bars on this slide represent the percentage of patients that were found to be appropriate for that particular setting when evaluated and studied case by case. And for this particular sample, which is pretty typical of Medicare patients, what you see is that home health, 86% of the time, was the right place for someone to go versus only 80% for skilled nursing facility, 69% for inpatient rehab, and 58% for long-term care hospitals. What are the implications of this? What this means is that people could have been sent home, for example, from skilled nursing facility and avoided the cost of potential complications of skilled nursing facility stay up to 20% of the time. And that therefore they could have gotten the right care, better care for them at lower cost. Similarly, patients were admitted to inpatient rehab facilities that could have gone to skilled nursing facilities or even potentially to home. So this demonstrates in a data-driven way that this study found that a lot of people who end up in facilities for post-acute care could have gone home with home health as a first choice and done just as well. Next slide, please. Let's take a more specific example of how this can work for a typical Medicare Advantage plan. So consider DRG 470, the DRG for knee and hip replacements. For an average plan with 50,000 lives, assume 300 members need a hip or knee replacement during the course of a year. For this particular plan, their experience, which is not unusual, is that 40% of those patients end up going to skilled nursing facility. By redirecting a number of those patients, it's possible to save nearly $400,000. If you also redirect the 8% of the patients who after surgery go to inpatient rehab, you can save an additional $100,000. And again, the goal isn't just to save money, which in this case adds up to almost $500,000 for one DRG, but to think about, can we avoid the risks of inpatient post-acute care? And there are real risks, risk of falls, risks of infection, things that patients can avoid by going directly home. So this example shows financially what the impact is of putting in place programs that focus on a relatively small number of patients. They can lead to really big payoffs. Next slide, please. In order to do this effectively, you have to have an approach that allows for clinical management and understanding of what the challenges are going to be in terms of getting patients to go home or to a lower intensity setting of care if they need inpatient rehabilitation. The first myth, I would say, is a lot of people, clinicians caring for patients, feel that those who live alone, they don't believe that people who live alone can't go directly home from the hospital. There's actually a recent study looking at joint replacement that found that those who did go home, when given appropriate home health supports, I'll talk more about that in a minute, actually do just as well as those who do not live alone. Secondly, discharge to SNF may be more of a habit than clinically necessary. As Steve mentioned earlier, a lot of the variability in post-acute care among Medicare beneficiaries is driven by decisions that are not made based on patient need. I was recently at a hospital and talking with their director of population health, who told me that in their 2-hospital system, after joint replacement at one of their hospitals, about 15% of the patients end up going to a facility. That's 15%. And at the other hospital, which is probably 10, 15 miles away, about 40% of the patients go to inpatient rehab after joint replacement. And that's because the surgeons who are at those 2 different hospitals have always done it that way. And when they talk to the surgeons, they understand that there are opportunities to get them to change the way that they think and assume how those patients have to be treated, and even do it before the surgery so the patients know what to expect, so that more patients can go home directly after joint replacement. And that's the third thing to consider, is that you can't just make blanket rules. You really have to take this case by case and understand the patient's specific needs. Not just do they live alone or not, but can they afford food if they are sent home? Do they have access to transportation if they need to get back to see their doctors, and they all do, within a week or so of discharge? Understanding the patient's specific needs is really critical to developing the right plan for that patient. It's the only way that they're going to be able to go to a lower cost alternative setting if they need inpatient post-acute care, or hopefully going home with services if that's what's best for them. Next slide. This just shows the specifics of, on average, what Medicare pays for those who are undergoing major joint replacement. This shows that if the patient goes home first, instead of going to inpatient rehab facility, that it's about $5,000 less per episode. And again, when you look into this and you see the variability that exists today across different hospitals, like I showed that earlier slide with the discharge patterns from the hospitals, you understand that those patterns can change without having a negative impact on the quality of care. In fact, they can improve quality of care and save costs and lead to better patient experience for those patients where it's appropriate to send them home first. Next slide. So earlier, talked about how this works for a surgical example for hip or knee replacement. This is an example of how earlier treatment at home for medical diagnoses can also decrease costs. And this study looked at what happens when you send patients home with chronic obstructive pulmonary disease, that's the chronic lung disease, or for patients with diabetes, or patients with chronic heart failure or CHF. If those patients are sent home with home health services in place, even though you're spending more money on home health services, you actually can reduce the total cost of the episode of care, because you often can reduce readmissions that happen to those patients after discharge. These are the patients that are most likely to be on medications that can be confused or confusing after hospital discharge. For patients with diabetes, for example, they're probably taking drugs that lower their blood sugars. If they're not taking those dosages properly, or if they've changed medicines and haven't gotten new prescriptions, that can lead to problems and higher readmission risk for them. That's why providing home health services to the right patients actually saves costs. It's sort of an investment that prevents further readmissions. Next slide, please. And here's the example specifically for chronic patients with chronic obstructive lung disease or chronic obstructive pulmonary disease, COPD. Turns out that about 11% of the Medicare population has COPD. Of those patients, about 6% total in the annual per year need to be admitted. So if you can avoid that group of patients that needs to be hospitalized from going home by themselves without support services, you'll actually save money. So that investment in home health services, and for these patients, who have respiratory problems, it may be valuable for them to have a short course of oxygen while they're recovering from their chronic obstructive pulmonary disease exacerbation or pneumonia. They may need IV infusions for certain medications like antibiotics that are more effective. It's really understanding, again, patient by patient, but understanding for a patient with a diagnosis like COPD, what are the right protocols? What are the right paths of care that can be targeted for these patients generically and then made more specific for the individual patients that can lead to better results? If you do this properly for a plan with 50,000 lives, similar to the surgical diagnosis we talked about a few minutes ago, you could save over $1 million a year just by making sure that you're paying close attention to these chronic obstructive pulmonary disease patients and getting them the right home services in a timely way so they don't have to be readmitted and go back to the hospital. Next slide, please. This slide actually shows not only the value of home health, like we've been talking about. This slide focuses on the value of skilled nursing facilities and the importance of monitoring length of stay to make sure the patients are getting length of stay that meets their needs, not just length of stay that's consistent with the number of days that are authorized by the health plan. What you see here is on the left axis, the y-axis, this is the number of discharges per day. And along the x-axis, along the bottom, are the number of days of length of stay, starting with day 0 when the patient is admitted to skilled nursing facility. What you're seeing is sort of spikes on day 7, day 15, day 21. Those spikes represent a larger percentage of the patients are being discharged on those days. What those spikes tell me clinically is that a lot of those patients, or some of them anyway, probably could have gone home a little bit sooner, but because the authorization was for that length of time, or in the case of patients, many of whom being discharged on day 21, skilled nursing facilities are used to discharging Medicare fee-for-service patients on that day because that's when it costs more for the patients to stay in the skilled nursing facility. These spikes are not due to physiologic or clinical needs. They're most likely due to the administrative, how long was the length of stay approved for that facility, rather than really understanding patient by patient what matters most. That's why having clinicians working directly with the facilities can often be helpful. Having nurses, for example, that can go on site to work closely with the discharge team and to see the patients can make a big difference to determine whether or not it's just, making sure the patient meets the medical necessity requirements, which many of these patients will, but really understanding where is this patient's care plan going, and are they really requiring stay in a skilled nursing facility, or can they go home with services if necessary? There is clearly an opportunity, and this is our experience, to really look at these length of stay data and understand better where are those opportunities. So to finish up my part of this, just a few things for you to think about from the health plan perspective in terms of where you can make a difference and how you can make a difference in post-acute care management. First, understand your discharge patterns. Look at those length of stay data for the skilled nursing facilities. Look at the discharge patterns from the hospitals. Better understand which facilities are outliers and where there may be opportunities to help them better manage those patients and to really make sure that they're targeting so that the health plan can target those right facilities. In other words, you need to understand where you start from before you can figure out what interventions make the most sense. In terms of then, once you've done that and you've identified where the opportunities are, you can look to see where the facilities that benefit most and what kinds of patients benefit most. And this is where looking at protocols to understand who can go home safely and what services do they need when they get home. So, for example, for a joint replacement, planning in advance before the surgery that the patient will go home, making sure the patient is aware of that, making sure that all of the necessary durable medical equipment are in place when that patient arrives home after surgery, making sure that all of the physical therapy needs for a joint replacement patient are assigned and taken care of and can be done proactively so that there are no surprises to the home health agency. All of those kinds of protocols can make a big difference in better managing the side of care and making sure the patient is getting the appropriate length of stay. Protocols can include skilled nursing facilities as well. Recently talking to an orthopedist who leads a musculoskeletal service line at a large healthcare system, she said they put in place protocols to manage patients after hip fracture that have reduced length of stay by up to 30%, with no increase in total cost of care and no increase in readmissions. So working clinically can make a big difference in how post-acute care is managed. This relates to point 3, which is home first should be the default. Obviously, there's certain kinds of patients where that will not be appropriate, but working with discharge planners in hospitals, working to support them with on-site liaisons potentially or nurses who can help them navigate the complexity of the home health environment and make sure the patient's needs are met when they arrive home, not a week later, of course, really goes a long way in helping, especially in hospitals where there's underutilization of home health and overutilization of inpatient facilities for rehab. Really helping the hospitals to develop a home first patient profile can be very, very helpful, and also is something the patients tend to like a lot themselves. Many people prefer to go home instead of skilled nursing facility or patient rehab, and if we can make that a reality, it's truly a win-win in terms of higher cost, fewer readmissions, better patient experience, and caregiver support as well. Finally, based on the sort of base benchmark understanding of where you are today, some plans may be underspending on home health. As much attention as that's gotten in the media over the last few years, you need to look specifically at your patient population to understand, are those home health costs low because you're overutilizing hospitals, skilled nursing facilities or other inpatient post-acute care facilities. And if you are sending people home without services, is there a higher readmission rate in that population that could be avoided if you had home health involved early? So if you think about these 4 things, know where you are today, understand how to better manage those patients clinically, develop a home first patient profile, understanding who can go home when it makes most sense to do that, and making sure then, if necessary, that you have adequate access to home health. All of those can really lead to better member experience and also to fewer readmissions. So Steve, back to you.
All right, thank you, Dr. Cantor. So I grew up on the hospital administration side in large academic institutions, and I could tell you at the time, the discharge process was somewhat chaotic. It was confusing. The timelines were aggressive. Patients, in some cases, were pushed out a door relatively quickly in order to make sure that they weren't staying there for an extra day. And it was almost a kind of a first come, first serve to the SNF opportunity, or whichever SNF would take a particular patient. And if there wasn't one available and you thought it was marginally safe, you could send a patient home with or without home health orders. The process hasn't changed that much over the years, and is still a current reality. And when you look at all the places, once a patient leaves the hospital where breakdowns can occur, there are many. And every one of those areas of breakdown is an opportunity to reduce costs and to improve the patient experience. So let me just highlight a couple things that you see on this slide. When a patient leaves a hospital, there are 64 different paths that a patient can take in some way, shape, or form. So this is a much simplified version of those 64 different pathways. But when you're starting over on the right-hand side, we believe that 8 to 10% of SNF admissions can be avoided with the right care at home. I tend to push the envelope. I honestly think it could be 40 to 50%, and based on changes in technology and home-based care and telehealth remote monitoring, I think that will continue to be, the home-based care as opposed to SNF will continue to be more and more of an option over time. Not only to reduce SNF, but also to reduce IRF, which we believe that about 30% of IRF admissions can be discharged to a less acute setting, in most cases to a skilled nursing facility, less likely to be into a home setting from an IRF. Down in the bottom right-hand corner, what we found in patients that we've helped manage and coordinate care for is that about 30% of all patients are discharged without orders that need some form of home health. They need a single nurse visit. They may need an NP to go into the home, and working to help identify who those patients are, facilitating orders for those patients can not only improve their experience, but significantly reduce the chance that the patient ends up back in the emergency room, which in most cases is the ticket to going back into the hospital. In the middle column here, when we're looking at readmissions, as we talked about before, about 50% of readmission expenses for patients discharged from a hospital alone with no type of support services. It's that subset of the population that you need to find orders for and figure out how to best mobilize care for them in the home care setting. And again, it may just be a telephone call. And it may be connecting them with a local church group. I mean, there's a lot of ways to look at the patient as an individual, identify what social determinants they need to be matched up with, and I'll hit that again here in a minute. So if we can move to the next slide, we could talk a little bit about the process that we believe should be followed as we move forward. So understanding as the patient's being admitted to the hospital for an elective procedure, or as they're about to get discharged, what's unique about that patient that's going to help you inform what their care plan needs to be, and what their first site of care post-discharge needs to be, and whether or not they can go home, and if they go home, what services do they need, whether it's a walker to promote mobility and limit the risk of fall, whether it's an antibiotic or hydration to limit an infection, which could push them back into the emergency room, or whether it's just making sure that they have transportation to get to their follow-up doctor's appointment or a meal in their home to make sure that nutritional needs are met. So embedding within the discharge management team and not just looking at the traditional clinical criteria, but looking at specifics around the patient. In this case, we have two patients, John Smith and Susie, and they were both admitted to the hospital for the same procedure. But if you look at John, he's living alone, he doesn't have a car, and he has a significant number of comorbidities and has been admitted to the hospital in the past, and will have some challenges with frailty given the fact that he's had a hip replacement as well. And when you look at Susie, no prior clinical history, lives in a single-story home with a husband and adult daughter who seems that's continuing to live with them. These two patients, although clinically may look very much the same for what they were admitted to, are very, very different individuals, and their care plans need to reflect that. And too often today in the discharge planning process, and as care plans are developed for the patient's not treated as an individual, they're treated as an average based on their diagnosis, or based on their diagnosis, with some sense of what their prior comorbidities would be. And by looking at the patient holistically, it's you're able to identify what the optimal path of care for that particular patient should be. So in this case, on the left-hand side, John Smith, recommending that he goes to a skilled nursing facility, and not just any skilled nursing facility, but a skilled nursing facility that has proven expertise to treat patients like him with conditions like his. And then post the skilled nursing facility, moving into home care, again with an agency that's experienced treating a patient similar to John. On the right-hand side with Susie, recommending that she does go get some care from a home health agency for a period of time, over a period of 25 days. You should be able to project what the costs are for each of these pathways up front, and by connecting the patient with the right care within the home, with the right nursing services where needed, you can reduce that readmission risk score significantly and reduce those readmission costs as well. So, what we're strong proponents of is a holistic, integrated approach to management of the patient. So, starting in the hospital, where should the patient go after discharge with a home first bias where it makes sense clinically? identifying how long a patient needs to be in a post-acute facility, leveraging analytical tools, identifying patients similar to that patient, making sure that you have liaisons embedded within the skilled nursing facility to be able to put eyes to the patient as well in order to manage length of stay and eliminate those length of stay spikes that Dr. Cantor talked about, which are created more because of how the SNF is paid and less because of how the patient needs to get treated from a clinical perspective. You need to assess how you prevent readmissions back to the hospital within the post-acute care facility. Up to 10–15% of patients can get readmitted from a post-acute facility back into the hospital in the first 4 or 5 days they're there. There's ways to work to prevent that collaboratively with your skilled nursing facility network partners in order to significantly reduce the facility-to-facility readmission costs. Then you need to understand what services the patients need at home. Again, do they need antibiotics? Do they need hydration therapy? Do they need a walker? Do they need a hospital bed? Do they need a nurse? Do they need an NP or a physician in the home? And assessing that completely in order to reduce readmissions once the patient's in the home. Supporting that patient and making sure they understand their discharge instructions, conducting medication reconciliation, which I think you all know is critical, educating them on signs and symptoms, making sure that you break down the social barrier connections, nutritional gaps, transportation needs relevant to that specific patient, and then involving the caregiver. I know, I would bet that many people on the phone have been caregivers of people in the hospital or in a skilled nursing facility, and it's a burden. And being there to support the caregiver is a huge asset, and again can help you manage costs for the patient as well by better engaging the caregiver in the patient's care directly. And then finally, the helping to coordinate follow-up appointments and making sure the patient gets there. And all of these components are interconnected, and all of these components are absolutely critical to the effective management of readmissions and total post-acute care costs. So in summary, as mentioned at the offsite, we do believe that managing post-acute care is absolutely critical to lowering costs, and the opportunity is real. They're real financial dollars, as I mentioned, $10 to $20 plus per member per month coming out of a bid. It's relevant to improving the clinical quality, direct and indirect impacts on star ratings. Readmissions management is a major star rating. Leveraging the home health network effectively and doing assessments on the home, the patient in the home can help with other star measures as well, which can support revenue enhancements, as you all know. And then finally, patient satisfaction is improved, which not only improves stars and HEDIS measures, but also improves retention, which is absolutely critical, and I know something that every Medicare Advantage plan is working on, every single day. Overall, we believe that the future of care overall is going to be in the home, and the home really can be the center of care. So the ability to coordinate the logistical needs of identifying what is the right support the patient needs in their home at discharge and on an ongoing basis, making sure those services are delivered at the right time and on time, leveraging analytics and appropriate clinical protocols to identify who's at the most risk for readmission, how to build the appropriate pathways to a patient that help them get home sooner, how do you best prevent adverse events for a particular patient, and then engaging that patient and the caregivers so they understand what's expected of them, what their obligations are, and where they're going to get the appropriate support to keep them safe and healthy at home is absolutely critical. We've built a care coordination and collaboration platform that's very, very specific on building bridges to the home, which we call HomeBridge. And over time, the types of services that can be provided in the home are going to continue to grow as technology continues to advance, as physicians and the clinical community become more aware of what can and cannot be done safely in the home. You will see more home hospice programs more home palliative-based care programs, more house call programs. It's like the doctor's black bag is coming back for a subset of patients and maybe the best way to manage certain patients, and then ultimately to do hospitalizations at home to avoid the acute care stay altogether, which we think is really going to be the future, where acute care becomes the exception as opposed to the norm, and care in and around the home becomes the norm. It's almost turning healthcare back on its head to where it was, hundreds of years ago in some respects, but supported by technology to make sure everything is clinically appropriate, the patient remains safe, and only by doing that are you going to continue to drive down costs even more. So with that, I will end and would be happy to take any questions anybody has.
All right, thank you. And as a reminder, ladies and gentlemen, to ask a question, please type it into the question and answer box on your screen and click enter. We'll start with our first question. In addition to Medicare Advantage, does this work for commercial populations?
Yeah, I'll take that. Yes, it does. I mean, when you think about the percent of patients that use post-acute care facilities for Medicare, it's 40% plus. For a commercial population, that's going to be, sub 10%. So but all the need to manage short-term stays within a skilled nursing facility for commercial populations. Many patients go for rehab. They may go for infusion post-discharge. A lot of those services can be done in the home. The financial value will be lower just because you have fewer patients there. On the flip side, in terms of readmissions management, the opportunity on the commercial side is just as great. On the commercial side, you're going to see 70 to 75, if not more, percent of patients go home alone. And the readmissions cost for those patients going home alone, again, will be about 70% of total readmissions cost. So the principles apply to both Medicare Advantage and commercial. The opportunities on commercial tend to fall more on the readmission side, less on the skilled nursing facility side in terms of total dollars, but the opportunity is clearly there.
Thank you. Our next question. For a health plan that is set part of a health system and has home care and SNFs affiliated with the system, how does this model work?
It actually works. Steve, I'll take a stab at this and you can add
Yep.
onto it. It actually works pretty well because in most hospital systems or integrated delivery networks or whatever you want to call it, there's a real effort to reduce leakage, right, to keep as much of the care within the system as feasible. So within that organization, the skilled nursing facilities and the home health agency or home health agencies, depending on how it's structured, may be the best performers or they may not be the best performers. What we tend to do is to try and support the system in identifying where the opportunities for improvement of performance in the skilled nursing facilities and home health agencies, and to give them the data and the tools so that those organizations can improve the quality of care that they're providing to those patients. And we also know that no matter how large the system, they will not keep 100% of those patients coming out of their hospitals within their system. They still need to therefore understand how do they choose. If they're going to send someone to a skilled nursing facility or home health agency, which one makes the most sense for that particular patient? Do they still really need to go to a SNF or a home health agency at all? What kinds of care do they really need? So the tools like the one Steve showed and demonstrated in terms of the best paths of care, those are really helpful actually, even for the integrated delivery systems, because they need to understand how to manage the patients that are going to sometimes go outside of their system and make sure they get the best possible care and coordinate it so that those patients come back into the system when they need ongoing care with their physicians or for other services. So this approach of understanding what makes sense, the best sense for the patient, using data to help drive that decision-making and discussion, and reporting to help improve quality across the post-acute care system, I think really makes sense not only for health plans that are freestanding, but also for those that are part of a larger integrated delivery system.
Thank you. Our next question, what barriers, for example, technology infrastructure, are you seeing around integrating community-based organizations into these models of enhanced home care?
Yeah, I mean, we believe that the community-based organizations have to be integrated at some level, and won't be right for all patients leaving the hospital, but the ability to connect the patient with the correct or the most appropriate community-based organizations based on kind of their belief system, we believe is absolutely critical. I think that the biggest barrier, to be frank, is just ensuring that you have visibility into what all those community-based organizations are within a particular area. We've done a couple things in different markets. We tend to inventory and or work to purchase lists of community-based organizations and then completely integrate them into the technology so that we can tee them up to a patient as they're leaving a hospital or a SNF, or to the caregiver for that matter. The other thing from a nurse coaching perspective is to ask the patient or the caregiver, what organizations are important to them, and then potentially put them in touch or make sure that they're connected. So we believe technology and awareness are probably the biggest barriers. The technology piece, we feel like we've solved. It's the awareness piece that is, sometimes the bigger challenge.
All right, next question. Are star ratings HHASNF of value?
That's a loaded question. I'll take a first stab, and Dr. Cantor, you can add here. I think star ratings are definitely of value at some level because you need some type of objective criterion for comparison. In all the analytics that we use today, we don't use the star ratings directly, but we do compare the CMS star ratings to the recommendations that we would make for a particular patient, and they overlap about 50% of the time. I think a star rating is it's based on an average for a particular institution, home health agency, or skilled nursing facility. The reality is, in many cases, a skilled nursing facility may be very good at treating patients with simple cardiac conditions, but not nearly as good at treating orthopedic procedures. And there may be a lot of reasons, ownership, physician affiliation, associations with certain hospitals or ownership that would drive those differences. But you could have a low star rating facility that does just a killer job treating certain diagnoses based on their history. So we think it's an important variable to look at. We don't believe it's the only variable you should be factoring in when thinking about designing a network or building a value-based network going forward.
Next, we find it difficult for hospitals in our area to come out of their silos to build networks. What recommendations do you have to work through this?
So, Steve, I'll take a stab, and then we can. This isn't surprising to me because for most of the time, the hospitals have been involved in managing patients. Their job was really to take care of the acutely ill patient, get them well enough to leave, and then they were kind of on to the next patient. They're starting to realize through things like bundled payments, through readmission rates that are now reported publicly, the quality measures that many health plans are holding them accountable to that include readmissions. Hospitals are starting to understand that they have to worry about what happens to the patient after they leave. And that's the key, I think, to getting the hospitals to effectively network, is to recognize the importance of determining if they're going to pay attention to what happens to the patient after they leave, which they should, that in their area there will be organizations that are better performing, in other words, higher quality compared to others. And what they should be doing is thinking about who do they have collaborative relationships with already, Are those organizations effective at managing post-acute care metrics like readmission rates, length of stay, total cost of care? Should they be putting out even a request for proposals or beginning to build networks using the data that they have or data that they can get? These are the kinds of tools that we have and that we use to really understand how to optimize that network for their particular patient population. And then how to, in the discharge planning process, how to optimize the discharge planning process so it guides the patients. Patients always have choice, of course, but really offers them choices that are going to be best in terms of higher quality, better outcomes. So that's what I would suggest, is it's really about engaging the hospital in a discussion around what's going to drive value for them as the hospital. How do they reduce their publicly reported readmission rates? How do they perform better in their bundle payments if they're involved in any? If they're considering bundle payments, the community organizations or the post-acute care organizations can often really help them think through how to make things better. So that would be my suggestion, is to really work with the hospitals to help them understand that by choosing the right partners, they can have an immediate and long-lasting impact on the quality of care that their patients receive after they leave the hospital.
All right. Next, what role would you envision home-based primary care playing in the effort to not only reduce readmissions, but to reduce initial hospital admissions?
Yeah, I love the concept of reducing.
Go ahead.
Yeah, I was just going to say, I love the concept of reducing the initial hospital admission, because I think that that's the end goal when it gets to really treating kind of the home as the center of the universe from a healthcare perspective. But, Dr. Cantor, you can take this. I know it's a passion of yours.
Yeah, I've been lucky enough to actually be one of those home-based primary care physicians in a previous life, working at a VA, helped set up a program, made a lot of house calls. There's no question that for the right patients, and Steve mentioned this during the presentation, you have to pick the right patients to make sure that those are the ones that will derive the most value. For them, it's all about reducing admissions in the first place. Ideally, it's about that for every patient, because the best way to prevent a readmission is to prevent the admission at all. And so home-based primary care can drive real value, not only because you can bring medical services and lab testing and all that to the patient, which makes it easier and enhances their access, but usually home-based primary care is a team-based model. So not only are you improving access to medical care, but also to nutrition and rehabilitation and social services, the things that can really make a big difference for that patient and his or her caregivers, because usually those patients have caregivers. Or if they're isolated, they need more support, and that's where home-based primary care can be helpful by coordinating that support, including the community-based organizations that we talked about a minute ago. Those kinds of programs for the right patients drive huge amounts of value and improve quality of life for those patients.
I think we have time for just one more question. Just a comment, it seems that a lot of the burden of tax falls on the nurses caring for the patient and a savvy social worker. The primary physician is like a CEO. Yes, that was just a comment, so I'm sorry. It's not really a question. Do you have any comment?
Yeah, I think it's always been, as a geriatrician, to me, my role has always been to support the other members of my team. So it is the nurses and the nurse practitioners and the social workers and the pharmacists and the nutritionists, psychologists, occupational therapists, PTs, et cetera, et cetera. It takes a village. And the physician's role is really to work on two things. One is to establish that relationship so that they can have, even when the patient's not sick, to have some knowledge of that patient and support them, and then to be able to mobilize the other resources of the team when necessary. And that's the second role, is to really get involved when the patient's complexity is rising or there's difficult diagnostic dilemma, something that really maximizes the use of that physician's skills so that everyone on the team is practicing at the top of their license. That's really valuable, and it's something that I think we all should be working towards, because when a team is able to practice at the top of their license, each individually and then as a whole, that delivers the best value in terms of highest quality and lowest cost for the patient and ultimately for the payers as well.
right. Thank you very much. Thank you to both of you for that great presentation and for sharing your thoughts today. Thank you to our audience for participating in today's conference. That concludes this webinar. Thank you again, and enjoy the rest of your day.